This brief video is intended to introduce the challenge that we're facing with regard to self-adjustment of insulin in type 2 diabetes in Nova Scotia. This is an initiative launched by the Diabetes Care Program of Nova Scotia, and our intent is to provide you with support around intervening to improve the uptake of insulin in type 2 diabetes. Observations that guide this project include the fact that early insulinization in type 2 diabetes appears to be a good thing, that the evidence supports this, but it does require us addressing two issues. One is the clinician inertia regarding earlier insulinizations, and the second is the attitude that the patient has, psychological insulin resistance. And it turns out that getting started on insulin is not the same thing as managing diabetes with insulin, and the evidence has been clear in showing that we can start individuals living with type 2 diabetes on insulin, but that doesn't mean that they can self-adjust the insulin, titrate it to the appropriate level. So we know that to be effective, insulin actually needs to be titrated and then adjusted, and that self-adjustment cannot be assumed. Getting started is not the same thing as achieving the goals. Why don't people self-adjust? And this is a question that serves as a starting point for guided self-determination regarding insulin management. That is, our job is to guide the individual to come to make the choice to follow the recommendations that they're being made around insulin. And it's important to appreciate that that doesn't happen naturally, that in fact people will follow their own beliefs more closely than they follow the beliefs of others. Self-management support rests on understanding the patient and negotiating treatment choices that become acceptable to the individual. So as we consider this question, why don't people self-adjust, it's important to understand that the relationship is really one that's not quite as straightforward as we would like. So we begin with a sensitive clinical encounter, hoping that this will directly lead to insulin administration and, of course, insulin adjustment of dosage. However, it's not the message sent, and importantly, it's actually more than the message received that's required in order for these outcomes to be achieved. Self-management choices are influenced by the thoughts and feelings experienced by the patient once the message is received. So clinicians need to be mindful of sending the message, evaluating how the message is received, and then importantly, starting to understand how that received message is experienced. And this leads us to address a number of particular barriers to insulin self-adjustment that this DCPNS project will attempt to help you with. There are cognitions that need to be identified. These cognitions fit into one of two categories: cognitive capacity. Are there issues of memory or concentration that would actually interfere with a person's capability of self-adjusting insulin? Importantly, cognitive beliefs. That is, the individual would have the capacity to self-adjust, but there are particular beliefs that interfere with this. And the two most common are psychological insulin resistance, attitudes that the individual has toward insulin that make it more difficult for them to adjust, or low motivation to increase diabetes self-management behaviors in general. So it could be specific to insulin, or it could be more general to diabetes management. And those two categories of beliefs become important for us to understand if we're going to overcome the resistance to self-adjustment. And there are emotional issues. In particular, fear issues, fear of hypoglycemia or fear of injections, and diabetes distress, which we know has become identified recently in the literature and is something that would be important for us to manage. The emotional experience of individuals can often be worked with if we look at what mediates emotion. So these are the kind of cognitions. What are the thought processes that go through a person's mind that is associated with emotional distress? And I just wanted to identify this so that we could use it as a framework from which to move forward. Insulin self-adjustment is often resisted because of cognitions and emotions. And it's helpful if we think about it from this perspective, that fear, or anxiety, nervousness, is actually the normal emotional response to the perception of threat. So when we see people who are experiencing anxiety or fear, we might become mindful of trying to understand what the perception of threat might be. Dysphoria, depression, sadness is the normal emotional response to the perception of loss, particularly the loss of something important. And irritability, anger, is the normal emotional response to the perception of intrusion or interference. So this is just to provide that groundwork for you. And what's in it for you? Well, diabetes management is really about self-management support, as I think we would all agree. Self-management support is mediated by the relationship between the diabetes care provider and the person with diabetes. And this really is reflected in a relationship that's guided by collaboration and empowerment versus teaching and telling. Common ground toward the uptake of clinical recommendations can be found by identifying what drives the current choices of the person with diabetes. This provides the context for assessing capacity, beliefs, and emotions, and it provides the groundwork for interventions to overcome these barriers. And this is just a brief introductory video, and we will follow with specific modules that will help you address issues such as capacity, beliefs, emotion management, etc. Thank you for your attention, and I look forward to our further work on this important project.